Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us for the liver cancer webinar tonight. Liver Health Foundation is a California-based entity. Many of the members of our board of directors represent liver patients and caregivers. Liver Health Foundation's Medical Advisory Council, led by Dr. Sami Saab from UCLA, has 30 members who are some of the best hepatologists and liver specialists in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for quality patient care, and host community and physician-centered educational programs. To see the complete list of our programs for 2020, please visit our website at www.liverhealthfoundations.org. Now I would like to introduce our exclusive sponsor for tonight's program, Exelixis. Mr. David Schmal, Senior Oncology Account Manager, will speak on behalf of Exelixis Pharmaceutical. David, would you please give us a little bit more information about Exelixis?
Thank you very much for allowing us to support the Liver Health Foundation. We at Exelixis are always looking for ways to be in the community and support like this. A little bit about Exelixis. We were founded in 1994, and we are based out in Alameda, California. And we're a company that strives to accelerate the discovery, development, and commercialization of new oncology products for difficult to treat cancers. So this evening, really looking forward to the presentations by Dr. Mellstrom and Dr. Bayani, and definitely looking forward to future events with the Liver Health Foundation as well. Thanks again.
Thank you, David. Thank you so much. We appreciate all the support that Exelixis and you have given us last year and this year. Thank you. Tonight's webinar is focused on liver cancer. This is the first installment of a three-part webinar. Unfortunately, liver cancer is the fastest growing cause of cancer death in the United States. Our goal is to provide information about liver cancer to liver patients and their families, and provide an opportunity so they can ask questions from our presenters. Thank you again for joining us. It is now my honor and pleasure to introduce Dr. Neil Bayani, who has generously accepted to be the host, MC, and presenter for tonight's program in Dr. Saab's absence. Dr. Bayani is the Director of Liver, Pancreatic, and Complex Cancer Surgery, Director of Reflux and Esophageal Surgery at the Association of South-Based Surgeons, Chair of the Liver, Pancreatic, and Gastrointestinal Cancer Program at Torrance Memorial Medical Center. Dr. Bayani's busy practice includes major abdominal cancer operations and gastric and esophageal surgery. Is genuinely interested in caring for patients with complex cancers, reflux, and abdominal problems using the newest minimally invasive techniques. Having had 3 years of extra training beyond general surgery, Dr. Bayani uses laparoscopy surgery to reduce pain and speed up recovery after major pancreatic, liver, stomach, and esophageal surgery. He regularly collaborates in clinical research projects with researchers nationwide to directly improve patient care. Dr. Neil Bayani has been voted a top doctor by Los Angeles Magazine. Dr. Bayani, thank you so much for your support. Please start the program.
It's my pleasure to introduce our first speaker and presenter, Dr. Lale Mellstrom. She's an associate professor and chief of surgical oncology at City of Hope. Dr. Malmstrom is a talented surgeon, an award-winning instructor and researcher. She was educated at Johns Hopkins University before getting her medical degree at Cornell. She continued her training at Northwestern Memorial Hospital in Chicago, and then her fellowship training in surgical oncology at Memorial Sloan Kettering Cancer Center. She's had professorships at Cornell and Robert Wood Johnson Medical Center prior to joining City of Hope. She's certified in robotic surgery and specializes in the treatment of liver, pancreas, melanoma, and sarcomas. Dr. Malmstrom has published over 100 peer-reviewed articles and is funded by the NIH, several foundation grants, and is a sought-after speaker at national and international conferences. With that, I'd like to ask Dr. Malmstrom, bring on the presentation. We're all very excited. Thank you.
Thank you very much, Neil. I'm just going to share my screen here. Okay, great. So I've been tasked to discuss bile duct cancer, specifically intrahepatic cholangiocarcinoma. Oh, one moment. So to put this in the context of framework, intrahepatic cholangiocarcinoma is essentially a subclass of cholangiocarcinoma focused in the context of cancers arising from the bile ducts that are primarily in the liver. These comprise 20 to 40% of biliary tract cancers. And they're really an incidental finding in almost a third of cases, 20 to 30% of cases. And as a surgeon, really surgery is the only potential cure. 30 to 40% 5-year survival. And I would say, having taken care of these patients the past 10 years, this disease is often and primarily a systemic disease. We know that there is worse survival in the context of lymph node metastases in patients that are rendered with an R1 resection, in other words, with positive margins, when there's vascular invasion, and if the tumor size is significantly large, or if there's multifocal disease. And when patients recur, the patterns of failure are primarily in the liver, peritoneum, and lungs. So systemic therapy, where do we stand in 2022? Back in 2010, the ABC2 randomized controlled trial demonstrated that gemcitabine and cisplatin were superior to gemcitabine alone, and they were able to demonstrate that the median overall survival for metastatic disease was 11.7 months versus just gemcitabine alone. It has now been 12 years, and we have not really moved the needle all that much until 2019, when the JAMA Oncology phase 2 trial was published, looking at gemcitabine, cisplatin, and Abraxane, which is nab-paclitaxel, demonstrating a median overall survival of 19.2 months in metastatic cholangiocarcinoma. Now, the caveat is that regimen is currently in phase 3 trials, and in having patients been on this regimen, for me, I've seen a great deal of toxicity. So despite the overall survival benefit, it is a challenging regimen to get through. But really, the needle moving 8 months would be quite remarkable for cholangiocarcinoma. The challenge and perhaps the opportunity for this disease is there are multiple etiologies that lead us to cholangiocarcinoma in multiple areas that can be targeted. These include developmental reactivation, oncogenic addiction, epigenome dysregulation, metabolic derangements, immune evasion, and then challenges in the microenvironment. And the cause of this disease has been seen essentially in the context of liver injury. So alcohol, viral hepatitis, diabetes, NASH, genotoxic factors such as asbestos, chronic inflammation, and liver fluke. So that is not quite an etiology in the United States. And so because there is generally a larger tumor mutation burden in this cancer compared to many of the other solid tumors, this really presents an opportunity. the Moscato trial demonstrated that 68% of biliary tract cancers had some viable actionable target, which is much higher than the 24% seen for all the other cancers evaluated. And really the most common molecular targets in clinical trials are PD-1, EGFR, VEGF, FGFR. It should be noted, though, that no targeted therapy alone has given response or disease control more efficaciously than chemotherapy. So I see the future as chemotherapy plus a targeted therapy agent. The one exception to this is in patients with microsatellite high disease, when they were treated with pembrolizumab in the KEYNOTE-158 trial, there was a 9% complete response and 32% partial response. This is much higher than what we see in gemcitabine and cisplatin, where the response rate is in the order of 23 to 25%. A recent targeted therapy that was approved by the FDA was ivosidenib, which targets IDH1 mutant chemotherapy refractory cholangiocarcinoma. This targeted therapy really only gave a progression-free survival advantage of a little bit over a month. I just put this trial as an example to show that the targeted therapies are promising, but they're not likely going to stand alone. Now, what about in the context of what do we do for patients after surgery, after the tumor is removed? And that's what we call adjuvant therapy. In the BILCAP trial, which is really the standard of care that still stands, was looking at capecitabine, which is essentially oral 5-fluorouracil versus observation. The overall survival in those patients is 52 months versus 36 months. Again, remember, these are patients with localized disease that have undergone surgery and marked improvement in overall survival. There was the PRODIGE 12 randomized controlled trial out of France that was also published in 2017 that compared gemcitabine and oxaliplatin versus observation. There was no difference in overall survival or disease-free survival. We're currently looking at gemcitabine and cisplatin versus capecitabine. That trial is pending, and we're very eager to see if we'll see any differences in survival between these two regimens in the adjuvant setting. So what about the initially unresectable patient? What can we do for that patient? Do we treat them with palliative chemotherapy, gemcitabine and cisplatin, or do we give them the more aggressive gemcitabine, cisplatin, Abraxane regimen? Do we give them immunotherapy? Do we give them targeted therapy? I would make the argument that for that patient population, the borderline resectable or the initially potentially unresectable, I would advocate for consideration for the use of radioembolization with systemic therapy, and then perhaps surgery based on their response. So I'll give you a couple of examples of patients in this context. Now, this patient, 63 years old, is my patient who presented with intrahepatic cholangiocarcinoma. He had some subtle lung nodules and lymphadenopathy and IVC impingement. That's the top image there. He was given Y90 and gemcitabine and cisplatin for 4 cycles. He was imaged and had stable disease, so he was taken to the operating room. Unfortunately, in the OR, he was found to have peritoneal disease, so we aborted the operation. However, this image here shows post-treatment 18 months thereafter. Now he's 30 months post-treatment currently, and he still remains alive and well. And I think perhaps with just systemic therapy, that would likely not be the case. And so the question is there evidence for this approach? Is there evidence for this approach for the borderline resectable or initially unresectable patient? In 2021, the MISFEC trial was published. It's a phase 2 trial out of France where they wanted to determine the response rate after Y90 and chemotherapy in unresectable intrahepatic cholangiocarcinoma. They gave gemcitabine and cisplatin for 8 21-day cycles with the radioembolization done at cycle 1 and then again at cycle 3 as needed. It's 41 patients, and the response rate was 39% by RECIST criteria, and 93% by Choi criteria. And that is a measure of the density of the tumor, the intensity of contrast uptake. Median progression-free survival is 14 months, overall survival 22 months, so nearly 2 years. But most importantly, 22% of the patients ended up going to the operating room, so 9 of the 41. And of those, 1 out of 5 had an R0 resection. And the recurrence-free survival was not reached in the surgery population going out to 46 months. So this gives us a window of some data to objectify this approach in this patient population. Another group looked at their data retrospectively in 169 resected intrahepatic cholangiocarcinoma patients. And they found that 32 of those 169 were downstage preoperatively. 13 had chemotherapy, 19 had radioembolization. And they saw that the overall survival was not really different between the upfront surgery and those downstage with chemo. However, on multivariate analysis, the radioembolization group was associated with an improved survival, with an odds ratio of 0.34. And if you look at the figure, the green line represents those patients that underwent surgery following downstaging with radioembolization or CERT. Again, another objective piece of data supporting this potential approach. I'll give you another scenario where the patient perhaps, the tumor is resectable, but perhaps the patient is either physiologically not able to undergo an operation or psychologically. This was my patient, he's 65 years old. I met him 1 month after his CABG and left lower extremity amputation as a complication of arterial access or injury from his CABG. He presented with resectable intrahepatic cholangiocarcinoma. He was at that moment not ready for another surgery and certainly very resectable disease. And so we opted to offer him radioembolization with gemcitabine and cisplatin for 4 cycles. And he subsequently, on the left is his presentation imaging, on the right is his post-treatment imaging. And he subsequently was able to go to the operating room and have a very, I would say, much more simple surgery that was really more parenchyma was preserved. He was in a better physiologic state for an operation, and he remains NED at present, nearly 18 months post-surgery. What about the role of checkpoint inhibition in intrahepatic cholangiocarcinoma? Currently, this question is being very aggressively asked, and there are greater than 22 immunotherapy trials in biliary tract cancers. And part of it is that there are several different immune subtypes in cholangiocarcinoma. And it's really the immunogenic subtype that we think this is most applicable to. Our GI ASCO meeting for 2022 was just a month ago, and one of the bigger headlines was the results of the TOPAZ-1 trial, which looked at durvalumab, which is anti-PD-L1 antibody, with gemcitabine and cisplatin versus gemcitabine and cisplatin alone. And that yielded a median overall survival of 12.8 months versus 11.5 months. Remember, this is the incremental movement that we've seen compared to the ABC2 trial that was done way back in 2010, so 12 years. And this may end up being the new standard of care for first-line systemic disease treatment for cholangiocarcinoma. So the TOPAZ-1 results demonstrate a 1 month increase in overall survival compared to the ABC2 trial, which was just gemcitabine and cisplatin alone. And so this brought, this made me think of this patient of mine who is, he's 68 years old. He presented with intrahepatic cholangiocarcinoma with marked lymphadenopathy. The top 2 images on the left are pre-treatment, where you can see the tumor that's in the left lobe of the liver with marked lymphadenopathy along the celiac axis. And the image below is the PET scan that shows the PET avid lymph nodes and the very large tumor. He had a needle biopsy that demonstrated poorly differentiated carcinoma. And per report, the tumor was positive for PD-L1, 90% of the tumor was positive. That patient, because he refused chemotherapy, he was treated with 4 cycles of pembrolizumab, and he had a marked response and subsequently went on to surgery. And afterwards, based on the trial that I discussed, the BILCAP trial, he received 6 months of adjuvant capecitabine. And I think what's notable for him is that he certainly had disease in the lymph nodes that were removed, hepatic artery lymph node, the left gastric lymph node, the common hepatic lymph node. But in the tumor itself, there was only viable cancer in 30% of the tumor bed. So he really had a marked response to immunotherapy. And I think the story is very much yet to be written about the role and the patient selection of who will receive immunotherapy for cholangiocarcinoma. And so I would say in summary, cholangiocarcinoma is a systemic disease. We certainly need to move the needle for survival as as an option to treat the entirety of the patient, as our 5-year survival is only 30%. Neoadjuvant systemic therapy is not likely to result in disease progression. So offering patients neoadjuvant chemotherapy or systemic therapy, especially in those that are perhaps we would say borderline resectable or physiologically not amenable to an operation, you will likely not miss a window of opportunity where you have 81 to 84% disease control. And then in those patients that are really kind of on the cusp of potentially not getting a negative margin, Y90 with gemcitabine and cisplatin is a tenable strategy for that patient population. And the future holds more tailored approaches that will likely complement rather than replace current chemotherapy. And that future is now. There are currently trials. We're looking at GemCis and nab-paclitaxel before surgery in patients with high-risk bile duct cancer. So including T stage greater than 1B, solitary lesion greater than 5 centimeters, multifocal or satellite lesions that are still technically resectable, and suspicious lymphadenopathy. We at City of Hope have 2 trials for metastatic patients. The first is a trial in patients that have already seen 1 or 2 lines of systemic therapy who are amenable to undergoing core needle biopsies. The triplet is an antibody to PD-L1, atezolizumab, with an antibody to CD27 antigen and a MEK inhibitor, versus the doublet, which is atezolizumab with the antibody to the CD27 antigen. Patients will continue treatment until there is progression or intolerance. And the primary endpoint is progression-free survival. The secondary endpoint is overall survival. And then a very novel trial is the safety of pressurized intraperitoneal aerosolized chemotherapy, or PIPEC, which is done laparoscopically in patients with peritoneal disease. So peritoneal-rich disease, they're treated with systemic therapy and intraperitoneal nab-paclitaxel. And really the goals are to see, assess the safety and really assess the preliminary efficacy of PIPEC in this patient population, which really has very limited systemic therapy options after they progress on first line. This is our team at City of Hope. The bench is very deep with our liver surgeons, my colleagues, Dr. Fong, Dr. Singh, Lewis, and Wagman, and our medical oncologists, specifically Vincent Chung and Dan Lee, who's leading many of these trials nationally. Thank you very much for your attention. It's an honor and pleasure to be here tonight. That's my email if anybody would like to reach out to me. Thank you.
Thank you, Dr. Melstrom. It's time for you and Dr. Bayani to have your cameras on, and we can get into Q&A with you and Dr. Bayani.
Lale, that was a great talk. Thank you so much. So comprehensive and so forward-looking. Some questions that we've been getting along the way. First is a question about the kind of the overall results in this disease. There were some people concerned, rightly so, about the kind of overall prognosis and results of treatment being or the relatively short life expectancy despite maximal treatment.
Yeah, this disease is, very rapidly evolving in terms of treatment options. From 2010 to 2022, it has not really been linear. And I would say the past 5 years, seeing that there are so many potential actionable targets in cholangiocarcinoma and the advent of using Y90, I think the future is bright. I always tell patients the median overall survival that I give you is dated. This data, the published papers are a reflection of the treatments given 5 years ago with patients being followed. They're not the results of patients today. Even the TOPAZ-1 trial, that's almost 3 years dated now too. So I would be quite optimistic, especially in those patients that have a singular lesion that was resected and they're getting adjuvant capecitabine. Though that median overall survival is 52 months, more than 4 years, much better than what we had perhaps 5-10 years ago.
Absolutely. There was a question about the role of transplantation for intrahepatic cholangio.
Yeah, so that has been a topic of discussion, for hilar cholangiocarcinomas. There are several centers that have protocols for transplantations, specifically Mayo Clinic is the one that I'm most familiar with. But usually for intrahepatic cholangiocarcinoma with vascular invasion and multifocal disease, transplant has not been traditionally used. We do offer hepatic artery infusion pump therapy for cholangiocarcinomas as another potential modality. I didn't really show that data today to get to resectability. That is really a resource intense approach, and you really need to go to a specialized center for that. And that's why I didn't really share that data today.
Excellent. Can you comment on any role of genetics and ethnicity in the etiology or pathogenesis of the disease?
So cholangiocarcinoma is not so much historically a family history related disease. And then in terms of the ethnic risk factors, they're not particularly one group that's significantly higher risk than others. Although you often see risk factors such as cirrhosis secondary to alcohol or viral hepatitis, or we're seeing more and more patients that have a history of diabetes or non-alcoholic steatohepatitis. I would say those are the greatest populations where we're seeing a rise in cholangiocarcinoma.
Excellent. And I think the last question that I saw was regarding biomarkers. Anything in that front that you're aware of?
Yeah, traditionally the tumor markers that we follow for cholangiocarcinoma is just CA19-9. It's a protein that's shed in the blood that we measure as a measure of response to treatment. We're looking at trials looking at circulating tumor cells to give us guidance after these tumors are resected and to guide us in terms of prognosis. But aside from that, there are not that many circulating biomarkers that are yet known. They certainly exist, but that are yet known in common practice.
Excellent. Lale, thank you again. Amazing presentation. Those are some great cases, some fabulous results for your patients. Thank you so much for sharing that.
Thank you.
Farah?
Yes, thank you so much, Dr. Malmstrom. We really, really appreciate your time. You're very busy. So now please allow me to reintroduce our host, our MC, and our presenter, Dr. Neil Bayani, one more time. Dr. Bayani is a director of liver, pancreatic, and complex cancer surgery, director of reflux and esophageal surgery at the Association of South Bay Surgeons, chair of the Liver, Pancreatics, and Gastrointestinal Cancer Program at Torrance Memorial Medical Center. Dr. Bayani, we are ready for your presentation. There we go.
Can everyone hear me okay? All right.
Yes.
So thank you again, Farah, and to the Liver Health Foundation for the opportunity to discuss hepatocellular carcinoma. And of course, Dave and Exelixis for providing the support for this. Today, we're going to talk in kind of broad strokes, 30,000 feet, about the risk factors, diagnosis, and treatments for hepatocellular carcinoma, and also some of the new and upcoming therapies around the corner. So first and foremost, who are the people at risk? Are you at risk? Hepatocellular carcinoma is a disease that is based on liver disease. So we're talking about people who have extensive liver damage, regardless of the cause, the most common things being viral hepatitis, excessive alcohol use, and fatty liver disease. Those are by far the most common entities causing liver damage in the United States and worldwide. But not far behind is inflammatory bowel disease, diabetes, obesity, metabolic syndrome, things that contribute to non-alcoholic steatohepatitis or fatty liver disease. Much smaller component is anabolic steroids, but specialists like Dr. Melstrom and I do see people who fall into that category. So what can we do? Well, the ideal thing is to catch these things when they're small. So there are guidelines on who should get screened. So patients who have chronic hepatitis B will develop or can develop hepatocellular carcinoma even before they develop cirrhosis. So screening in this population is particularly important to discover early disease. Once people have cirrhosis, then the risk for hepatocellular carcinoma goes way up. And in fact, most people, if not everyone, falls into a high risk category, but particularly Asian males younger than the age of 40, females older than the age of 50, and Black males above the age of 40. Again, this is based on American populations, but these patients really are at above average risk. Including in the screening is not just an ultrasound twice a year, but also measurement of alpha-fetoprotein. So alpha-fetoprotein is a protein shed off the outside of hepatocellular cancer cells that falls into the blood and can be measured. Not all hepatocellular cancers have this protein on them, and so it's not necessary that people have this in their blood when they have cancer, but oftentimes it can be helpful to measure this. Unfortunately, as with many things with screening, only 20% of eligible patients are actually getting screened. And again, the recommendations are twice a year, but only 2% are actually getting twice annual screenings the way they should. The symptoms. As with most cancers, unfortunately, you really only see symptoms when there's advanced disease. At that point, you're seeing things like jaundice or weight loss from liver decompensation, ascites or fluid in the abdomen when the liver is overwhelmed, and then fullness and bloating, just generally feeling crummy. So the diagnosis is most commonly made with ultrasound, CT, or MRI. On CT or MRI, this is actually a very unique point to this particular malignancy, this cancer, is that there are criteria that have been set aside for the radiologist to judge how likely this is to be cancer. And based on that, we can actually avoid biopsy in a certain percentage of patients if they meet all the criteria. So if they have certain characteristics on imaging or if their alpha fetoprotein AFP level is above a certain threshold, we can actually have a positive diagnosis even without an invasive biopsy. The most common way we talk about treatment categories or staging for hepatocellular carcinoma is not your standard stage 1, 2, 3, 4, but we've talked more about patients' liver health, their performance status, the degree of cirrhosis, and how much disease they have. And we put all those things together, and we use something that was originally developed in Barcelona, probably close to 20 years at this point. And through this flow chart, which you can see, which is kind of complicated, categorize somebody into someone who can have treatment for cure or less invasive treatments, or if someone is really particularly unhealthy, the best we can do is support them. But let's talk about cure. And yes, even with this disease, there is a chance of a cure. The two most common modalities, one is transplantation, removing the entire liver and giving a fresh one, and the other would be surgery. Now, transplantation treats both the cirrhosis, which is the cause of the disease, as well as the actual disease itself. Of course, the number of organs available for transplant is limited. It is a major operation with very strict criteria, and you must be fit enough, including abstinence from alcohol. Generally, surgery, resecting or removing the cancer, is much more commonly available. It does only treat the cancer by removing it, and so it does not treat the rest of the liver. And so that actually becomes a limitation in a particularly diseased liver that is severely affected by cirrhosis, that sometimes surgery is not optimal or possible. But in 2022 and over the last 2 decades, even these major operations on the liver can typically be performed minimally invasive through small incisions, which minimize pain and speed recovery. But what if we can't cure this? For a variety of reasons, whether the liver is unhealthy, the person is unhealthy, or a variety of combinations of the tumor. Well, we do have other particularly effective treatment modalities, one of which is called ablation. We can put a needle probe into the tumor and using either radio frequency or microwave energy, generate heat to where the tumor is cooked to the temperature of 70 to 80 centigrade. And this is particularly effective in smaller tumors. In fact, for tumors less than 3 centimeters in size, the efficacy is almost as good as surgery, and you could almost say that it's curative. But for larger tumors, the best you can hope for is to downstage them. And potentially, this is a way for people to have larger tumors or multiple tumors treated while they're waiting for transplantation, if that is the goal. Again, other treatments that we have, one is called transarterial chemoembolization, or TACE, or any kind of embolization, which comes in the varieties of plain embolization, where we just clog the arteries that feed the tumor, oftentimes using glass spheres. There are these spheres that come with chemotherapy attached. That would be the chemoembolization. And Dr. Mellstrom has alluded to it in her presentation on cholangiocarcinoma. We have the ability to treat internally with radiation, again, attached to these beads that are injected through the artery directly into the tumor. One of the newest modalities is external beam radiation. Just like taking an X-ray, where low doses of radiation are used, external beam radiation uses targeted, higher doses of radiation directly to try to kill the tumor. Radiation treatments typically range from 5 days to 20 days, depending on the dose and the tumor size. This data is relatively new. It's only been around for about 5 to 10 years, but is quite promising. The limitation is, again, the possibility of damaging some surrounding liver. And so most of the data here is limited to people with early cirrhosis. So there's a significant amount of trepidation and caution when using this in patients with more advanced cirrhosis. However, it is seeming to work out to be a very good alternative to the previously mentioned treatment therapies. Immunotherapy. And once again, I need to give a lot of credit to researchers like Dr. Melstrom and companies like Exelixis and to Dave for the advances here. For quite some time, we didn't have very much by way of drugs or chemotherapy. We were using highly toxic agents without great results. But over the last 3 years, we've had a variety of things come up that have really changed the entire landscape. So if you can't have transplant, surgery, or if you've already had chemoembolization or ablation or radiation, you can still get drugs, including checkpoint and VEGF inhibitors, which is currently the first line treatment. This has now become so good that it is the #1 recommended modality for treating patients who cannot get other things or who have already had not curative treatments as a systemic option. We also have tyrosine and multi-kinase inhibitors, including the product by Exelixis, cabozantinib. And these are really advancing in how we're able to prolong life and sustain people over time. So this is truly an exciting time to be part of treating this disease. We've had a lot of advances in just the last 2 to 3 years. And I think part of it is we're exploring multiple different ways of coming at this disease. And this is certainly an overwhelming diagram, but it just shows the multitude of ways that we're researching coming at this. Everything from using vaccines and viruses to inoculating or training our own cells or patient cells to attack the tumor, and then using antibodies to checkpoint inhibitors or different ways of treating it, hopefully in a way of, again, moving this disease forward in the treatment of patients who can't have curative surgery or transplantation. And with that, I'd like to once again thank you guys for having me, to Dave for all the work that Exelixis has done in sponsoring this, and for Farah and the Liver Wellness Foundation. Thank you so much.
Thank you so much, Dr. Bayani. And we are now in the Q&A session with you. I'm gonna pretend I am you and hopefully be able to pronounce all the names that are in the questions for you. So one question I actually have myself, if the tumor is small and in one location, my understanding is that the liver is the only body organ that can regenerate itself, internal body organ. Can they cut that portion out and let the liver grow to its natural normal size?
Absolutely. So the best treatment for hepatocellular carcinoma, the best chance of cure, truly is removing the cancer. Now, whether that's removing a portion of the liver with traditional surgery or with removing the entire liver cancer inside with transplantation, the best treatment, hands down, is removing it. If you have someone with a large tumor and a significant portion of the tumor is removed, the liver will essentially regrow to meet the needs that your body has. The liver will determine what size it wants to or needs to be in order to support the body. The caveat there is, of course, if the liver is severely damaged in people who have extensive cirrhosis, the liver's ability to regrow is impaired. And in those patients, we as the surgeons and people taking care of the patient, liver specialists, hepatologists, have to determine whether or not surgery is safe and there'll be enough liver left behind to sustain the person.
Right. Right. Is there a chance that, say, the conditions are right and you cut a portion that has the cancer in it, is there a chance that the regrowth will develop cancer again? Is there something inherent in that liver that's bad?
That's exactly right. And that, unfortunately, is one of the limitations of removing it. You still have the remaining liver, which is damaged and is prone to developing another hepatocellular carcinoma. And so that is one of the advantages to transplantation is you're removing the diseased liver and preventing recurrence or a new tumor forming in that remaining liver. Absolutely.
Yes, you talked about burning the tumor. Does the burning or even including radiation in the other treatment that you mentioned, do they impair any kind of liver functions? Or did they hurt anything else, any other organs around the liver or on the way of the radiation?
Absolutely. So again, the specialists here are doing their best to spare the surrounding organs. Surgically, when we're working, we're able to physically move the other organs out of the way. But if you're doing a needle ablation, putting the needle directly through the skin into the liver, or you're shooting radiation from the outside, you don't have the ability to move other things out of the way and protect the organs. What they are able to do is target things very carefully using the latest technology, CT and MRI. And with that, they're able to, generally speaking, preserve the other organs and limit the damage to other organs, or even limiting damage to the liver itself.
Thank you. The other question that I'm reading all these questions, I'm not that smart to come up with all those questions myself, but question is, are the symptoms of cirrhosis different in men and women?
Yeah, to my knowledge, no, I can't say that I've heard that. Cirrhosis is cirrhosis regardless of gender or race or ethnicity. The symptoms of cirrhosis are, developing jaundice or discoloration, yellowing, as well as developing increasing abdominal size with the presence of fluid, and then abnormalities in the blood work that show that the liver just isn't able to perform its normal functions.
So this is my question. Why the screening rate is so low, and what can we as patients, you as a specialist, we again as advocates for liver patients, what can we do to raise awareness and change this? I mean, 2% for the second examination, that's very, very low.
Yeah, it is really unfortunate that this is not more widespread. I think part of the problem, to be honest, anecdotally, is a lot of these diseases happen in underserved communities and in populations that don't have as good access to advanced care as many others. And so you do see significantly lower screening rates in minorities and in rural areas and in underserved communities. And I think there is a disparity here that is underlying parts of this. And then the other thing is screening requires follow-up from patients. It requires vigilance on the part of the providers and caregivers. It's a very complex multi-level task. It's not just a one-time vaccine or what have you. So it's a difficult situation, but I think there's some healthcare disparities in play also.
That is one of the issues we are going to be working on, to put some webinars and hopefully when it's safe to do seminars on disparity in access to healthcare. Because I think that's a huge issue and that we can really be talking about it and bringing it to the attention of powers to be. Maybe we can start the change. So thank you so much, Dr. Bayani. Excellent, excellent presentation. I learned a lot and I appreciate you being presenter, MC, and the host as well. I also want to thank again Dr. Mellstrom and Dr. Bayani for their support, for being here. We know your lives are very busy between your work, your family, and I really appreciate that you're supporting us. Thank you. At this point, we have something that we've never done before, but we want to do this. We have a public announcement, public service announcement. I am going to ask Ms. Rodriguez to turn on her own camera to speak to us about this clinical trial that the Cedars-Sinai with their affiliates are doing on non-alcoholic fatty liver disease that we all know as NAFLD, and the worst case of it, NASH, that is now becoming an epidemic in the United States among even school children. So Ms. Rodriguez, would you please turn on your camera?
Hi, Farah, can you hear me?
Yes.
Yes, okay. Hi, my name is Elvira Rodriguez. I'm a nurse practitioner here at Cedars-Sinai Hepatology Department. As Dr. Bayani had mentioned, NASH is one of the leading conditions predisposing people to hepatocellular carcinoma. So in concerning this, we are actually conducting a clinical trial regarding the role of lisinopril in preventing the progression of NAFLD. The study is called Relief NAFLD. So as we know, fibrosis or scarring in the liver is related directly to the progression of hepatocellular carcinoma. Therefore, we are looking at the effects of lisinopril in fibrosis progression following a 24 weeks on the agent. And it is an open label study, so all the participants will get the actual medication. The study has an accrual goal of 45 and is now enrolling at 3 different sites. So there's one at Cedars-Sinai here at Los Angeles, one at Duke University in North Carolina, and Mount Sinai Health System in New York. Our lead academic organization is Northwestern University, and we are also working under the National Cancer Institute. So for all who are in attendance today, if you or someone you know has advanced liver disease or cirrhosis due to fatty liver disease, we invite you to participate in the trial, and our contact information is on the screen. And FARA is kind enough to also post it in their website. So for people who are missing this webinar, hopefully they could see this also in the Liver Foundation website. Thank you.
Absolutely, and people can scan your QR
QR
code
code.
also
Yes,
if
ma'am.
they don't have enough time to jot down all the information.
Correct.
So very good. All right. So
Thank you so much.
thank you. I'm very happy we were able to host you.
Thank you.
Rodriguez, this is a good cause, and we are proud to be a partner with Cedars-Sinai.
Thank you.
All right, thank you. All right, again, thank you to Dr. Malmstrom and Dr. Bayani. I want to invite everybody to please register for our rare pediatric liver disease webinar on PFEC. Tomorrow, yes, tomorrow, 2 nights in a row, you will see us at 5:30. So if you are interested, please go into our website, liverhealthfoundations.org/programs, so you can register. I thank you all for attending this meeting tonight, and I look forward to seeing you next month and tomorrow and the month after that. So thank you and good night. Ari, are you there? No, I guess she left. Okay.